Here's a connection most people never make. That winter flu you think is just a miserable week in bed might actually trigger a stroke or heart attack. Research shows influenza and respiratory infections dramatically increase cardiovascular event risk within the first 7 days of illness, with hazard ratios of 3 to 5-fold. Let me explain why infections and cardiovascular catastrophes are intimately linked. When you contract influenza, your body launches a massive inflammatory response. Cytokines, inflammatory signaling molecules, flood your system. This isn't targeted inflammation at the infection site. It's systemic inflammation affecting your entire cardiovascular system. These inflammatory markers make atherosclerotic plaques unstable. The fibrous cap holding the plaque in place gets weakened as inflammatory cells migrate in and digest structural proteins. Your blood becomes hypercoagulable during infections. Coagulation factors increase, platelets become stickier, and clot formation is promoted. From an evolutionary perspective, this makes sense. Your body is preparing for potential tissue damage and bleeding from infection. But in modern humans with atherosclerosis, this hypercoagulability turns dangerous. A rupturing plaque plus hypercoagulable blood equals vessel-blocking clot. Fever increases metabolic demand dramatically. Your heart has to work harder to supply oxygen to tissues with elevated metabolic needs. Heart rate increases, sometimes 20 to 30 beats per minute above baseline. Blood pressure often rises. For a healthy cardiovascular system, this is manageable. For someone with limited cardiac reserve, it can exceed capacity. Dehydration accompanies most respiratory infections. Fever increases fluid loss. Reduced intake because you feel terrible compounds this. Dehydrated blood is thick blood. We keep coming back to this because it matters so much. Blood viscosity affects everything from blood pressure to clot formation risk. Direct viral infection of vascular endothelium occurs with some viruses. The endothelium, that delicate lining of your blood vessels, gets damaged by viral invasion. This triggers inflammatory responses and can directly promote clot formation at the damaged sites. What makes this particularly relevant to winter cardiovascular risk is that infections and cold weather are both occurring simultaneously. You have baseline cold weather vascular stress, blood thickening, and increased blood pressure. Then you add systemic inflammation, hypercoagulability, fever, and dehydration from infection. The cumulative stress can overwhelm cardiovascular compensation mechanisms. The timing pattern is remarkably consistent across studies. Maximum cardiovascular risk occurs in the first week after symptom onset, particularly days 3 to 7. This is when inflammatory markers peak and when fever and dehydration are often worst. Prevention through vaccination is tremendously important and underutilized. Influenza vaccination reduces cardiovascular events by 15 to 45% in at-risk populations. That's comparable to many cardiac medications. Yet vaccination rates remain disappointingly low, especially among people who would benefit most. The mechanism isn't just preventing infection entirely, though that helps. Even when vaccinated people do contract flu, it's typically milder, meaning less inflammation, lower fever, and shorter duration. All of these translate to reduced cardiovascular stress. Timing of vaccination matters. Getting vaccinated in early fall provides protection before flu season peaks. Waiting until midwinter means you might catch flu before immunity develops fully. For people at cardiovascular risk who do develop respiratory infections, early antiviral treatment is critical. Medications like oseltamivir work best when started within 48 hours of symptom onset. They reduce symptom severity and duration, which translates to reduced cardiovascular stress. Hydration during illness becomes absolutely critical. Force fluids even when you don't feel like it. Specific goals matter. 8 ounces of fluid every hour you're awake. Water, broth, herbal tea, whatever you'll actually consume. Monitor urine color as an indicator of hydration status. Some cardiac medications require adjustment during acute illness. ACE inhibitors and diuretics might need temporary dose reductions to account for fever and dehydration. Aspirin timing might need discussion since you're already taking it for fever. These adjustments should be discussed with your physician in advance, creating a plan for what to do if you get sick. Warning signs that distinguish dangerous from routine illness progression include chest discomfort, severe shortness of breath beyond what the respiratory infection explains, heart palpitations, or severe dizziness. These warrant immediate medical attention, not waiting to see if they resolve. Post-infection recovery deserves attention too. Don't immediately return to full activity. Gradual resumption over 1 to 2 weeks allows inflammatory markers to normalize and cardiovascular function to stabilize. Pushing too hard too fast during recovery has triggered events in people who had weathered the acute illness successfully. The broader message is about recognizing infections as cardiovascular stressors, not just respiratory nuisances. That winter flu is testing your cardiovascular system as significantly as intense exercise or extreme cold exposure. For people at risk, infections demand heightened vigilance and proactive management. Vaccination isn't just preventing illness, it's preventing heart attacks and strokes.